3 minutes past, and so I think we'll make a start. Vanessa is on the train, so she will be here if she can get here before the meeting finishes. That's Councillor Churchman. We haven't got anybody. We haven't got anybody on the on Teams, have we? Oh, we got Michelle just coming on Teams. And we're still expecting Darren and Leslie. We're still expecting Darren and Leslie, are we? As far as you know. Yeah. Okay. Well, we'll make a start anyway. So, Joe.
Chair, could I just give my apologies if we're still going strong at 7:15? I need to leave.
I think there's a number of people who say they've got to leave at 7 or thereabouts. So,
Chairman, I'll just remind members now we need 4 members to keep the meeting formal. So, yeah, we'll lock the doors at 7 o'clock after one's gone, and hope everyone can remain.
Thank you, Paul. So, Policy and Scrutiny Committee for Health and Social Care. Welcome and thank you for your time. So we'll start with apologies. Paul,
yes, Chairman, we've got it's sort of like the World Cup. We've got a few substitutes tonight because of refreshed lineup. So we got Councillor Joe Lever, and as the chairman said, Councillor Churchman's meant to be attending, but she's being delayed in traffic. So we got apologies from the Vice Chairman, Michael Lilly, Councillor David Adams, and Councillor Claire Mosdow, Chairman.
Thank you. So minutes of the previous meeting. Can we have a proposer and seconder for that, Richard and Rodders? Right, declarations of interest. If you can't think of anything at the moment, and you do at the time of the item, just announce it then. Nobody's got any declarations of interest so far? No, good. Public questions?
We've had none notified, and unfortunately,
no members of the public here. So, item 5, outcomes and recommendations arising from previous meetings. So we've got a progress report, 5A progress report, which we've received.
Just gives an update on some of the actions agreed at the previous meetings, Chairman. There's a couple still in the pipeline, so to speak. So we'll need to progress those at some stage.
Notes on the informal meeting that we held.
This Chairman, you recall that our meeting unfortunately coincided with the passing of Queen Elizabeth, and therefore we couldn't have a formal meeting, but I felt it appropriate for a record of the discussion. That we had some very good, robust discussions at that meeting, and I think it was only right for that to be properly recorded and placed on the public record.
Good. So, item 6, pressures on the healthcare system. So, I think, Michaela, would you like to open on that?
How long have you got? So, I submitted a paper, but I'm conscious, with my sincere apologies, I submitted it late, which is partly a reflection of the issues I want to talk about. So I'm not sure if people would have the time to read it, so I'm going to run through it. It is a paper that has been contributed to by all of my colleagues across the island. So it's a paper about the pressure on the wide remit of health and social care services. If I just pull out of the highlights, and I'm pretty sure that most of you will understand the pressures because you only have to turn on the media. And what I should say is I wrote this paper before we had significantly increased pressure on paediatric services, which you will have also seen covered in the media today around strep A and everything else. But if I just update you on what's in the paper. So in terms of the overall position, if I start with acute services, I think it's fair to say St Mary's is seeing very significant pressure on its demand for urgent care services. Attendances at the emergency department are 10% higher than they were in the same week last year. We don't compare to 2020 because it was an odd year, but we compare back to 2021 and they're 10% higher. And that's about the same as all other hospitals in Hampshire. Emergency admissions are only around 2% higher than they were last year, but people are staying longer and are generally sicker. And we've definitely seen an impact on acuity of care post the pandemic. Our occupancy at the trust is around 97%. Most of the time it goes above 97% at some points. And compared to pre-pandemic, there are 40 more beds open at the trust than there were before. So there are 40 escalation beds. And over 100 patients spent more than 12 hours being bedded in the emergency department whilst they were waiting for a ward during October. And at the moment, on an average day, between 25% and 29% of people who are in the hospital are actually medically fit to leave the hospital, but we really struggle to find onward care capacity, and we've talked about that lots of times in this meeting in terms of staffing that. I would say that means that staff at the hospital are under significant pressure, and I know we've said this in the paper, but we absolutely need to thank everybody across every health and social care setting for their hard work, because it is really tough out there at the moment. There is some good news in the paper, and I should really stress that. So the Isle of Wight's ambulance service is maintaining absolutely exceptional performance despite those pressures. The Trust was the best performing ambulance service in the country in October 2022 for category 3 and 4 calls, and they should absolutely be commended for that. You will have seen on the media lots of coverage around the country about ambulance holds and ambulance handover delays and people waiting outside hospitals. And I can categorically say that does not happen on the island, because we know that because of our small size and the number of ambulances, it would pose real risk if we held ambulance delays. But that is why you see people waiting for 12 hours in A&E, because we get them into the hospital. Primary care is under significant pressure. Primary care appointments are up around 4% compared to the same month last year. However, one thing that I thought was really positive to note, and you might have seen the national publication of data last week, but 80% of all appointments are now face-to-face, and that is really positive for us. I'm going to let Laura cover the adult social care section in a minute, which is section 4, so I'll just skip over that. In terms of the actions we've taken across the island, we've taken a number of actions, and they have mitigated the pressure on services, but they have not in any way eliminated the pressure on services, and it is going to be a really challenging winter for health and social care. So things I would say is we were allocated a first tranche of £1 million of additional winter funding, and with that we've opened 17 short stay beds in partnership with Laura and her team. We've put additional funding into Mountbatten Hospice, who you all know do some fantastic work, and they are looking after more people who are being discharged from St Mary's and looking after them in their own home, which is really good. We've put additional capacity into trying to have primary care, what we call resilience, so extended access appointments, and we've also worked to support 2 voluntary sector schemes that are really focused on carers and keeping people well at home. We've extended something called the virtual ward, and you might have seen this banded around nationally, but a virtual ward is essentially effectively trying to care for people in their own homes but give them medical support in their own homes. And we have capacity for 22 more beds on the Isle of Wight than we had last year. We've put some funding into working with people who've got respiratory conditions. There's a lot of evidence base that Simon will talk about far more eloquently than I will, but there's a strong evidence base around having what's known as rescue plans for people with respiratory conditions, so making sure they've got a really clear plan of care and they've got antibiotics ready in place at home. And obviously we've been working extremely hard on the vaccination programme, and at the point of writing the paper we'd hit 80% of the most at-risk local people being vaccinated against COVID-19 and flu, and you're probably seen in local media that we are still offering COVID and flu vaccination clinics. And when I last met you all, there was some concern that we hadn't been able to maximise the rollout, but actually we've done significantly better in the last few months, and that's going well. I've included at the end some comms messages, which I probably don't think I need to run over here again, but you'll know all the messages we're going out with to the public to support people. If I can just ask Laura to comment on the social care section, is that all right before we take questions?
So from an adult social care point of view, demand mirrors that we're seeing across health. It continues to be very high, and the capacity to deliver is constrained by our workforce challenges across all services, and vacancies in social work, direct care provision, regardless of employer, is impacting directly on capacity and the ability to support and care for people. There is significant recruitment activity underway collectively as a system, but also regionally and nationally, and we're starting to see some impact from that recruitment activity. The key challenge continues to be the ability to recruit the number of staff that we need to effectively manage demand. And that's largely driven by a lack of equity in pay with health and other sectors that we continue to see challenged, not only here on the island, but nationally. People who are needing adult social care support are on the whole very poorly and requiring higher levels of care than they previously have done. In addition to those increased needs, there's a level of complexity that we've not seen before in adult social care. Whereas before a person needed social care to maintain their levels of well-being, now they're needing it to maintain their health as well. And traditionally, where health services would have stepped in, local authorities and adult social care providers are carrying some of those tasks, whereas before they didn't. Occupancy levels in care homes across the island continue to be consistently high, and the average occupancy levels are now at about 98% consistently. We see very few beds available locally. We see a lack of specialist beds, so where that complexity is high, we're unable to safely care for those people within the island's geographical boundaries and are having to look for care and support in other places. What's key in those decisions is that the person is safe and receives the care and support that they need, and those are the discussions that are taking place. A similar picture exists with home care, and whilst we've got a number of home care providers on the island, their capacity is also very stretched. We know with our home care providers, they're experiencing higher rates of staff absence due to a variety of reasons, and that can lead to care rounds needing to be organised at really short notice, or family and friends being asked to step in and provide support, where ideally we wouldn't be in that situation. The introduction of the discharge to assess pathway, which was a national programme, has also significantly increased the work of adult social care. In essence, my service is now supporting almost double the number of people leaving hospital as it was prior to the introduction of the scheme in 2020, 2021. That obviously continues to have impact. Whereas before, a person who funded their own care and support would, on leaving hospital, make their own arrangements, the discharge to assess pathway sees them all come into the care of the local authority for an initial period to enable them to stabilise in an environment before their final destination is determined with them and with their family. And during that period of time, our resources are on hand to support them in the way they would anyone else. There's no criticism of the discharge to assess pathway. It's absolutely the right thing to do. Getting people to the right place and supporting them to remain as independent as possible is critical for us as an island and for our local residents, but it has increased the burden on adult social care without the funding being increased to enable us to identify sufficient resource to be able to meet that new and increasing need. Back to you, Michaela.
Okay, thank you, Michaela. I just want to thank you for a lovely, simple, direct, easy to understand report, straight to the point. So thank you very much for that.
Hey, Laura will smile at this, but we quite often go through papers. I've got like 45 different diagrams in them, and I did think about sending a PowerPoint presentation of 45 diagrams, but actually like, just because you can see that, but actually you don't need that, do you? Like the key messages are in there and I don't need to explain to you all how difficult it is. I know.
Have we got any questions on hospital pressures? Anyone? Joe?
Oh, just very striking. Is it right, Michaela? You're saying 25 to 29% of occupancy is for people who are medically fit to go on elsewhere. Yeah.
That links to what Laura was saying in terms of the major challenge we have. We have actually done really well. We should commend ourselves for this in reducing the length of stay in some of our onward care settings. So some of the nursing homes and reablement and rehab services, you will know, are working really effectively now. But the problem we have is there are so many more people who are coming into the hospital sicker and then being identified with care needs that we haven't got the onward capacity to keep up with them. So we've talked a lot here, haven't we, around domiciliary care staff, but also, you know, care home staff. And we just, this is, we do have a high percentage, but that number is pretty consistently across England, you know, around 25 to 30%. And that is a national problem that we are going to have to grapple with. And it does have an impact. It does cause an impact because essentially health services and social care services are now operating on a one in, one out basis. And we've put in a lot of extra capacity to try and help us get through the winter, but it's still not enough capacity. So the fact that people are waiting a long time in the A&E department is because we can't get that flow through the hospital. But as Laura said, there are also people in the community who have got really high needs that we struggle to meet. And the predominant factor in that is a workforce one. And we've talked about workforce here before, haven't we? And everything we're talking about tonight in reality has got the same underlying theme, but workforce is the fundamental backbone of all of that.
Richard, Councillor Quigley.
Several questions, which is probably easier to distill them into one. Well, two actually. What would the normal number of percentage of patients well and waiting to leave stuck in hospital be compared to now? Because I know 29% is high, but what would be a normal?
National average is higher than 20%. I don't know the figure, but I'm really happy to find out and let you know tomorrow. I don't. I know most of the southeast region, where I look at the stats every day, sit at above 20%. Pre-pandemic, it was lower than that, but it probably wasn't still. You know, we still had around 10 or 12% of beds occupied, but it has become worse. And the main reason, there are two reasons for that. I think, although it might not feel like it sometimes, like the buoyant jobs market doesn't necessarily help us, because as Laura's talked about before and I've talked about before, attracting people into those roles is really difficult. And we particularly struggle on the island, don't we, because of the number of people over 65 who don't have any family members. So a lot of people were being maintained with their family and carers who are looking after them. And we have a demographic that means we're always going to be at the really high end of that percentage, essentially. And
I think the last few meetings, it just feels like, and this isn't meant as a criticism, just that it's always a sticking plaster. What would be the magic wand? What would you want if you could do anything, Michaela? What would you want to do?
I think on this one, there's loads of things. On this one, money is not the only solution. So funding is definitely a part of it. But in reality, there is a long-term requirement around addressing the workforce and wanting the social care workforce setting to be somewhere where people are proud to work. And Laura will describe that better than I will.
I guess my wish list includes parity in terms of pay and value society places among care workers with their NHS colleagues, rather than being seen as the poor relation, being respected and viewed as the true profession care work is, would be really important. Secondly, I'd love more money. I haven't got enough money to do what I need to do, and the absence of funding means that I can't afford to financially reward those carers in the way that they deserve to be financially rewarded. And then, I hope this is music for my colleagues here, a healthier population. If we all take a bit of responsibility, we all build our own resilience, and if we look to our future, thinking about prevention rather than constantly thinking about a reactive health service, will only stand us in better stead. If we continue in the way we've continued for the last 40 years since the NHS, longer than that, since the NHS became a free resource at the point that people need it, it isn't sustainable. We need people to start making better and healthier life choices to enable them to manage their own healthcare needs moving.
Councillor Lee.
Thank you. Apologies if this has already been covered previously. This is my first time at this committee. When we say people are getting sicker, can we just expand a bit more on that? Is that a predicted thing? Is that a hangover from the pandemic, or is it something that we think will end, start to?
So what we've seen in healthy life expectancy, which has kind of been exacerbated by the pandemic, and that's due to our life circumstances and all sorts of things during life. So yeah, lots of diseases, people are living longer in sickness. So at the end of the years when the hospitals and social care are looking after them, so that's one of the challenges, led in part by our lifestyles, led in part by the way that we work and deprivation, those kind of things.
Michelle, did you want to say something?
Yeah, I didn't know Simon was there, and he's much better placed to answer these sort of questions. But we are in a quite deprived area, and that increases incidence of some preventable illnesses. But as Simon has said, the ageing population will increase our long-term conditions and increase the acuity of illnesses. But I think we particularly face on the island an issue where many people come to retire on the island and without their family networks, and then unfortunately lose a loved one, and then end up with poor social networks, which does really impact on all services. So there's lots of factors for why we have issues. The other issue is that we're always firefighting, and that prevention is really the way forward. But sometimes we're always trying to deal with the next thing. So at the moment, it's obviously the issues that we're having with infection due to bacteria, Streptococcus A. But actually, that will take up a couple of weeks of intensive work. So we're quite often firefighting, and really we need to be doing a much more preventative programme.
Thank you, Michelle. While you're on, so we talk about the back door at the hospital, and of course the front door is through primary care.
Absolutely.
Through prevention, and we've mentioned prevention. There's a little bit more to dig down into that with the peer review in a minute. But what is primary care doing to increase its capacity, particularly with the proposed change in legislation for providing longer hours, Michelle?
Absolutely. So we've been open for Saturday on Saturdays for many years now, actually doing planned appointments. I'm delighted to say that, as Michaela's already referenced, our activity is back now above 2019. Just to put that in context, we see approximately 22,000 patients per week across the island, approximately 86,000 patients in a month have some sort of contact with primary care. That's not necessarily seeing the GP, but we have extended allied professionals working within our team. So, nurse practitioners, pharmacists. So over half of the population have a contact with primary care every month, which I think is quite staggering figures, actually. So, but your question, John, about, sorry, Chair, your question about what we're doing to increase our capacity. We put on extensive additional capacity through the winter. So we offer support to 111. We offer additional appointments during the week to support surgeries which may not be offering enough appointments. And obviously we're open Saturdays. We do also appointments now from 6:30 through to 8 every evening throughout the island. That is divided through our PCNs. So just to remind everybody, we have 3 PCNs on the island, and those appointments will be provided at a PCN level, so that can support patients that need advice in the evenings. We offer a real range of appointments on a Saturday, so certainly long-term conditions, which we've already mentioned, can be reviewed, supporting people that work. We offer appointments for women that might need smears, for example, and they're working during the week. We do smear appointments at the weekends as well. So we are really offering a range of appointments. We've increased our capacity. 80% of those 22,000 will be at face-to-face. I think the take-home message often is that may not be with your traditional GP, but with the best person that can suit your needs. We have presently a new musculoskeletal practitioner at my surgery, and you know, she is amazing and will do a much better job at your musculoskeletal issues than I would. And so being booked in with her is not anywhere near second best. It's actually the best thing to do. So patients really need to understand that we're trying to get the best professional for them to see to support their needs. But yes, so we're doing lots, Chair.
Michelle, is it fair to say that what we talk about as a GP surgery is actually more a primary care organisation, offering far beyond what a GP would traditionally offer?
I think what we've done is that over the years, we know that there is a chronic shortage of GPs. And so traditionally, the jobs that we would have done, a medication review, for example, seeing those people for neck pain and back pain, we now lend those out to other health professionals so that we can try and focus on the areas which perhaps others can't do, as perhaps more essential for us to do. So older persons, medicine is more complicated, and so GPs end up doing that. I think it's fair to say that we know that there's a chronic shortage of GPs, so we have diversified the workforce. And I think that we do offer a much greater range of services than the traditional GP would have offered. We can also look at things like we've got mental health advanced nurse practitioners that deal with people's mental health. We've got social prescribers, which can help people navigate the system. And those are definitely a much wider range of services than primary care traditionally provided 10, 20 years ago.
Thank you, Michelle. I think to communicate that would be very helpful, because just the reiteration of GP services makes people think that you've got to go and see a GP. And I know Councillor Quigley and I have made some efforts in that in the Cowes Peninsula, and we're going to continue along that vein. So thank you very much.
Thank you.
Councillor Carl.
Thank you for allowing me to intervene. There's a couple of questions that come to mind that whilst here, just thought I'd ask really. I'm really trying to understand this issue about that people are presenting more ill, but leaving hospital more ill than previously. And I think that that's something that we need to understand, because that's the impact which happens on adult social care. The more ill, they need more care. What is it that's causing them more? You know, if the illness itself is greater than previous, how are we understanding that? Because if we can bring that greater illness down, we can help that. It's So I'm just asking, because we need to understand that, because that will reduce the pressure. And I think the other thing to say is that money is absolutely critical at the moment. There's no doubt about it. Is that, you know, because of rising costs and everything else, the fact is that we're pretty flat in terms of where we are. So I think there's no trying to run away from the audit committee. You know, we clearly saw there. So this year, because of the impacts, we are £3 million down already in adults, or projecting to be by the end of the year £3 million in adult social care in terms of what we're supposed to do. Next year, we still have to make a cut of the £3 million, which is austerity, you know, the general package, which is continuing, and 3 million this year, 3 million next year, and we're finding it difficult. But in addition to that, and the bit which is really going to hurt us next year, is this gap of, you know, £10.4 million that we're talking about. That's after an assumed income from the local government settlements and everything else. So money is really critical at the moment, and that will, unless we can address it, which we're working really hard to do, that will result in a reduced level of service on the island. There's no doubt about that. Government must give us more money, bottom line, because otherwise the service will continue to reduce and the pressure increase. And there's no way that we can generate money internally, given the pressures, certainly not to the ability of 10.4 million. And then we've got pay settlements and other things on top of that. So I'm saying that there, you know, I don't want to be fearful, but we have to recognise that the pressure is significant now and is increasing because of the lack of finances directly from government. And we don't have the ability, even with our 2.2% council tax, which we've been allowed from the settlement, that only produces 1.8 million at best, 1.5 million probably by the time it's all adjusted, people haven't paid, etc. And a pressure facing us next year, potentially in the region of, after all of the adjustments, £9 million for adult social care alone, which is then part of the 10.4. So it's quite a complicated story. So money does matter if we want to continue to provide the levels of service that are necessary to support local people now. So we're going to get a tax increase and less of the service as it stands right now, unless government give us more money. And the 2.4 million or 2.6 million they're giving us, I've forgotten what that will not touch the size in terms of what we're facing. So it's really important to understand that.
Oh, thanks for giving that message so strongly. Michaela.
So I'll let Simon talk about the health needs piece. So from my perspective, I think it's really clear. So if there is any reduction in social care capacity,
yes,
and that percentage increase of people who are medically fit but cannot leave hospital because they need onward care increases, that just reduces the capacity to treat patients with health needs. That is the reality. So what Councillor Love is articulating would put even more pressure on health services if we are unable to if more beds are not used effectively, in essence.
Thank you. Any questions? If not, we'll move on to, it takes us nicely into the next item, which is with public health and in particular the peer review. Simon, would you like to lead on that, please?
Many thanks, Chair. So you've got a paper in front of you that in part was presented to this committee about a year ago, presenting the partnership. As part of that presentation, it's about the partnership between Isle of Wight Council and Hampshire County Council for Public Health, which enables that senior specialist leadership and a strong public health function for the council here. As part of the presentation here about a year ago, we were asked to do a review, and with talking to colleagues and working out the best way to do that, an independent review led by the LGA was undertaken in September, just gone September 2022. And so what I have done is added that outcome of that into the paper. There's a presentation I can talk through as well, but let me just give a quick summary, if that's okay, Chair. It's probably the helpful way to do it. So it really was helping to think about policy prioritisation and budgets. As we've heard, there is pressure on the system, and actually if we don't invest in prevention, that pressure will get worse. We know that people with poor health need more healthcare. We could think about physical activity, we could think about smoking, we could think about healthy weight, and a number of other things. So that's the purpose of the public health function. We're on bullet 13 of the paper. So led by the review team, they found evidence of significant progress providing safe, high quality public health services. And that was something that had to take place when the partnership started. And I'm really pleased and hearing stories today, working with Laura about the work of our drug and alcohol services, working with colleagues in adult services. And we've got a strong sexual health service that have really led that response around monkeypox. So you can see there's a number of things we're doing. And even today, I've been on calls today, as we've talked about with the Group A Streptococcus, so doing all that work. They found that now we have clear structures and processes in place to support the function and a team that are working really well. Our joint student needs assessment previously wasn't of a strong value. It's now really strong, looks at the needs of the people and can drill right down. As we talked about earlier, Chair, we can go down to local communities to understand those needs. We've strengthened the skills and the capability of the team to really improve the health of the population, and we're beginning to see outcomes improving. I think the report noted there was really good leadership around improving health and tackling health inequalities, working with members, working with partners and others. And it's been really key working with the newly emerging ICB and ICS. I'm not saying it's not without complications, but actually that's developing with Michaela and others in place. So that's really positive. With our new joint health and wellbeing strategy, Island Health and Care Plan, what we have done is embedded public health throughout. So some of the work around the community strategy, we're not having a separate public health strategy. We are in there asking every single theme to think about public health. And I think Michaela and Laura agree that's the way we've done it. And that's been really good to focus on those. We're continuing to think about quality improvement with our service provision, really monitoring those outcomes for the population. So yes, we can, as it were, get a number of people through a smoking service or a weight management service, but what are the outcomes? So we are doing that. I think we got thrust into the limelight with COVID, and you can see our community disease oversight. As I mentioned before, we're doing much more of that, and we have set up an Island Health Protection Board to oversee that area, including vaccinations, including outbreaks, and including situations such as we're dealing with now. We've met for the first time to really scope that out. So we used to meet weekly during COVID. We've now moved to a different rhythm, which is really important. We're really looking to build on the community engagement work and think about how we do that. We understand our communities well, and we just need to think about how we further that. Our great example is Peach, which is our program in schools. So really working with those school communities to improve the health of those pupils and their communities and their parents. And that's been really, really positive. Doing some work on falls prevention in a similar kind of way, not with schools, but with communities. As others have said, recruitment is really challenging. We are not without that challenge. So we are trying to work innovatively around the specialist public health workforce to ensure that we can deliver our mandate and our function of the council. We have our first public health apprentice on the island, really, really positive. And what we have managed to do, the local course isn't very accessible if you live on the island, but we've got an online course with the University of Bristol, West of England in Bristol. So that's really positive. We've really seen that in the last few months, and this person is really developing well to grow our own. So I think overall, the review supports the partnership with Hampshire, and it does enable a local focus on the island. Me and the team are embedded in the island, but also in the system. So you get that both focus. So I was in a meeting developing the ICP strategy as a whole, but I'm there representing the island alongside the leader and the chief executive. So we're providing that senior leadership to the council, the health and social care system to ensure that we meet our functions. Shall I stop there, Chair, but happy to take questions.
Yes, yeah, I think overall the LGA review is certainly worth doing, but it was a very good review. It would be interesting to know to see quite how you take on the areas for further consideration. And I know from our earlier conversation that you've already recognised the potential of greater community engagement, particularly through town and parish councils, and those with place plans, as Councillor Quigley and I have already taken that initiative in the Cows area, where our wards are. But the further considerations talks about more focus on outcomes. So we know what you do, but what difference does it make, Simon?
It's an interesting one, isn't it? And I think there's something about it was quite a short spaced review, as in 3 days, and for them to look at outcomes. I think when you look at our contracts, so that's mainly with our provided services, we have to look at the number of people coming through the service and what their outcomes are. I can say today I've had the report from nationally around alcohol services and drug services, and we've seen a 10% increase in the number of people completing treatment. So those kind of things are the outcomes we want to see, and it's really trying to move that through. In terms of sexual health, obviously sometimes it's quite hard to look at the outcome, but we look at sexually transmitted infections and teenage pregnancies, and they're all going in the right direction. But equally, we want to look at access to services. It's really important that we do that. Some of the other ones around weight management services and smoking, we want to wait a bit longer because we know that there's no point in looking at someone who's given up smoking on day 1. We look at 12 weeks. So again, we're seeing a real change there, and that's been really, really positive. We've invested in the smoking service, which wasn't in the place you would expect a smoking service to be. I think going forward, John, you know I do regular reports. I'm very happy to bring those reports on process and outcomes to this committee.
Thank you, Simon. Much appreciated. Joanna.
Thank you. I've just got a question. We've talked about the importance of prevention and preventative services, which we can't argue with. And I just wanted to stress the importance of the voluntary sector with regards to preventative work, and to ask you if you work with or commission voluntary sector organisations, given their key focus on prevention and working on the ground with people in their own communities.
So for me, you're right, we need to take a systems approach to prevention, because it's not about services, it's about how do we think about working with roads to make our people able to cycle more and feel safe. How do we work with those communities? So we do have small grants, and we evaluate that with the voluntary sector. And there's something about also recognising the services commission are specialist public health services, so they've got nurses, doctors. So some of those aren't suitable for within the voluntary sector, but where it's suitable, we do work things like falls prevention. We are working with communities and places like that. I think Laura may be able to add to that.
I wonder if I may, and I think part of our system is we focus often on the relationships between the local authority and health, and what we tend not to see so much is the relationships between the statutory organisations within the Isle of Wight Council. Simon, Steve Crocker for Children and I work really closely together, and Simon's team were instrumental in terms of the contract we let around living well and early help, so engaging our voluntary sector in that whole preventative agenda and keeping people in a place where they choose to live for longer. So that preventative work stream is thoroughly embedded within adult social care, reflected in our care close to home strategy, which aligns with the public health strategy and which is core to our commissioning activity as well.
Very appropriate. Leslie's turned up at this point, so it's interesting, that partnership. So you know, we know our roles. Leslie's very absolutely focused on the kind of treatment, and that's something we're working in partnership to make sure they dovetail together, so that we know we can do our preventative work. And I think that shows the kind of work we're now doing together.
Thank you. Councillor Downer Brothers.
Thank you, Chairman. Yeah, Simon, I'd just like to ask you, about you speaking about smoking prevention. What about e-cigarettes? Surely they're just as bad. Thank you.
Interesting question. So e-cigarettes are better for you than smoking a cigarette, because the chemicals, you don't have all the extra chemicals, you're having the nicotine. What we don't want to do is start a new craze of people smoking e-cigarettes, but they are very good as a quit tool for people to quit, and they're very, very effective in that sense. So that's how we use them, and we don't, obviously we're not saying people should take up e-cigarettes, but we want to use them as a quit aid.
What percentage of success have you had with people giving up on tobacco smoking then? Would you be able to put a percentage on it?
With e-cigarettes or in general? So I think we're in line with the national average. So about 50% of people who come through our service give up. Bearing in mind, most people who give up smoking take 7 times of giving up before they actually finally give up. So we do very well, and e-cigarettes is part of that.
Also, I think it's a question of willpower, because my father smoked since he was a nipper, but when he got to about 60, he just threw his tobacco in the window and called that it.
And there's some people who you might technically term a catastrophic quit, so they do it just like that. But actually, we know that if there's support, which we commission, specialist support, alongside some kind of pharmacotherapy, people are much more likely to be successful, which is why we really promote that, working with Dr. Legg and others to say, you know, if you're supporting someone to give up smoking, don't just do it on your own, refer to our service and we can help.
Thank you. Councillor Quigley and Joe.
Thank you, Simon. Please, again, don't take this as a criticism, it's a general question. Is the previous evidence we heard was people are not living as long, life expectancy is dropping. What is frustrating you most about when you took the job on? Because when you took the job on, if everything that happened you'd wanted to happen, we'd all be 106 before we went. And that's not happening. So what are your frustrations? What isn't happening?
So I guess for me, what I want people to do is to live as long as possible in healthy life, rather than, you know, so there's kind of thinking about life expectancy, healthy life expectancy, so that actually people have fulfilled lives, as we all want to kind of live as long as we can and then die with the support we would like. I think for me, what we've seen increases in levels of obesity. We've seen smoking drop. So it's those kind of things that we really need to tackle together, because actually the hospital can't do it, primary care can't do it. We've got to do it together. As I said, how do we all see a culture change where we support that? I think there's even some more we can do. I think smoking's not gone away yet. I think there's even more we can do. And we work very closely with the Trust, really pleased with the work we are doing around helping people quit smoking. Smoking and pregnancy rates on the island need to be lower. And we're working very closely now with maternity, and that's having an impact. So those kind of things are a culture change, and it's how we do that in the environment we've got. And I think we're on that journey.
Thank you. Councillor Lever.
Thank you, Chair. When we talk about prevention, and then we mentioned about part of that solution is people making better choices, essentially. It was good to hear Simon talk about it's okay saying that, but we need to enable people to make those choices, right? So it was good to hear Simon talking about the roads and making people want to cycle and able to cycle. But it would just be good to understand more about what short-term things can we be doing there, and then, because obviously the longer-term things require much more infrastructure and much more planning. But what are the short-term things we could be doing in that space?
So I think you're right, some of it's long-term, but actually some of the short-term things we can do, we think they're long-term, they're short-term. Let me give the example of smoke-free legislation. Within 6 weeks, we saw a drop in heart attacks, whereas we thought that's going to be long-term. So how do we think about that? So working with our parks colleagues to make smoke-free parks for children. How do we think about things like the daily mile in school, getting children more active, which actually will help them concentrate at school, but also then thinks about their weight. How do we work with retailers around healthy choices and making those accessible? So some of the things around the community pantries that we're working with is making sure healthy choices are there. And then back to the comment earlier, vaccinations. How do we think about flu, COVID and other vaccinations so we really protect our population from this? So some are short term, and then you get short term wins that actually encourage people they can do it and they can make a change, and that's positive for their lives.
That's amazing. Thank you very much. So we'll move on to.
Chairman, before you move on, I think we've looked at the LGA peer review, because there is still a doubt or a requirement to look at the future of the partnership arrangements with Hampshire. And I think the cabinet member, before he wanted to take the report to cabinet about the continuation of the partnership, wanted to get the views of this committee. And I think now that you've heard of the independent LGA peer review on how well the partnership's working, I think perhaps the committee would better be in a position to recommend to the cabinet that the report be taken on the future of the partnership, with the support of the committee that it is doing the job it intended, but also with the peer review, I presume there's an action plan to be drawn up. And I think that it will be inherent on you moving forward over the next couple of years, Chairman, to monitor the actions to make sure that they're actually being delivered. And if there is a resource requirement, then obviously you give the backing to the cabinet members for those resources being made available. So if members would want to endorse that the cabinet member takes forward the partnership arrangements to cabinet with the backing of this committee, and that will continue to monitor the delivery of the action plan from the peer review.
Do we have a proposal to that effect, Joe?
I'm happy to propose those things, Chair.
Richard second them, right? Okay, and we'll go to the vote. So those in favour?
That's unanimous, Chairman.
Thank you, Paul. So item 8 now, the safeguarding adults board reports.
Chairman, unfortunately, the chairman of the board, Teresa Bale, has indicated that she's unwell and unable to attend, but she's asked Laura if she'd kindly step into the breach, dear friend, to fill that void and present to the safeguarding report.
Thank you, Laura.
I apologise for being a very poor substitute for the independent chair of the Safeguarding Adults Board. I'm hoping that this isn't unfamiliar. There is an annual report that comes from that independent board, which outlines key activities and is accompanied by the board's business plan. Teresa, in the forward to the report, provides you with a very detailed summary of the board's challenges and activities over the last 12 months, and the report goes into far greater detail than certainly I would be able to at this moment in time. The report provides you with information around membership and structure, along with the subgroups, the work they're undertaking, key policies and procedures, and also some of the main areas of activity that the board have undertaken over the last 12 months, including their work around domestic abuse, the work around raising awareness, and certainly the fire safety development group, which has been a key change and a key move forward for us as a board over the last 12 months. Accompanying the report is the business plan, and you'll note it's for 2022 to 2024. We're slap bang in the middle of that 2-year business plan. It's ordinary for the board to have just a single year business plan, but recognising that there were some longer term objectives, a 2-year plan was put in place last year. The plan is due to be reviewed in February when the Safeguarding Adults Board has its development day, and that board will also, on that development day, look at the constitution and refresh that if necessary. Provision of a Safeguarding Adults Board is a statutory requirement. It's part of the Isle of Wight Council's duties to discharge it at this moment in time. As the statutory officer for adult social care, aligned with our chief executive, we're satisfied that we're discharging our statutory functions in that area. It's not necessarily the way we will continue to do things in the future, but it's certainly right for the Isle of Wight at the moment, and it's on that basis that we're happy to continue with the arrangements we have in place and with the 2-year business plan. I would like to take the opportunity to thank Teresa for being our independent chair. She does a brilliant job of herding cats on many occasions, and when you have a board with so many interested stakeholders and statutory partners, it can be challenging to get us all on the same page. But the key underlying principle of that Safeguarding Adults Board is recognising the challenges, but taking the learning that comes from those challenges to help us improve lives for local people. I'd also like to thank Emma Coleman, who's the board's manager, who provides all of our support for Teresa to enable the board to function effectively, properly and lawfully, and Emma does a fantastic job in that space. I'm happy to attempt to answer any questions you have in relation to the board. I have promised Teresa I will take away anything I can't answer, and will certainly provide a substantive response if I'm unable to in due course.
Right, Joanna.
Thank you. I've just got a comment, and I want to absolutely echo what you've said. We work with Healthwatch across the country, and we recognise how lucky we are to have such a strong independent chair, because a lot of other areas don't have such a well-functioning board that we're lucky enough to have. And the focus of the chair is very much on listening to people's voices, and particularly those people without a voice. And much of the work is based around that priority, which is again unique amongst local safeguarding board. So we are very lucky and privileged to have the chair and the manager that we've got. A lot of good work, and they have great outcomes. They are very effective in their work, and they lead on a lot of work which across the region, which is replicated and recognised. So yeah, just want to echo what you said and recognise how lucky we are to have them.
The committee notes and appreciates, indeed recognises the good work that the board does and wishes to express its thanks at this point. Thank you. Any other questions? No. Okay. Now we move on to the thorny subject of dentistry and the appalling mess that the NHS England of commissioners have managed to make of it, which has been subject of this committee for many occasions. One of the questions that I would particularly like to ask at the head of this is the handover of commissioning being exercised as smoothly and as cooperatively as it could do, given the bad track record of the commissioning under NHS England?
Thank you, Chair. So my colleague Joe, who hopefully will appear on screen in a moment, Joe York, is the the screens have just gone. That's perfect timing for me, isn't it?
Hello, sorry, apologies. I was waiting for somebody to let me in because it said I'd been disabled, my camera and mute button had been disabled, but obviously it's been unmuted, so apologies. So yes, welcome to, my name is Jo York. I'm one of the managing directors within Hampshire and the Isle of Wight ICB, and I'm the interim lead for the transition of all the delegated commissioning of dentistry, optometry and pharmacy. So I will do my best to answer your questions tonight. I think in terms of that initial question, yes, that handover has been smooth and is going well, and I can explain that to you if you would like me to start there and how that works. I think NHS dentistry, as you say, there are a number of challenges that dentistry faces across the country. Oh, I don't know, can you still hear me? I think I've disappeared from the screen, have I? Ah, I'm back again. Apologies. You can hear me, can you, Chair?
Yeah, you're still there.
Good, thank you. So whilst I understand your frustration at NHS England, I think we also have to recognise that they are very small regional teams doing very difficult jobs and very specialist contracts with a huge number of contractors across the southeast region and nationally. But I won't dwell too much on that, but I would say, you know, it's a very small team that has been looking at this, and they've been doing their very best in challenging circumstances. So in terms of the transition, that is going well. We are one of the first areas in the southeast to take on delegated responsibilities, so we went early, recognising some of the challenges we had in the area. We are still working very closely with the other ICBs in the southeast region, and we have a committee in common that helps the ICBs make decisions and make sure we are still working as a collective and still ensure that we have that consistency of approach. And we're also working very closely with the NHS England commissioning teams, because as I said, these are quite small areas and they are quite complex contractual areas. So that expertise sits within that team. And they're working to support all of the ICBs, and that transition is going well. I think the main benefit of moving delegating commissioning from NHSE to the ICBs is that alongside that consistent approach and managing that small resource well, we also get to be more flexible, to be better able to commission against local need, and to build the relationships with the providers, because I think that's been the biggest challenge for NHSE operating at such a large scale. So that's what we're doing. We recognise that in Hampshire and the Isle of Wight, we have some really significant challenges around access. And the Isle of Wight is probably one of the areas where that is the most acute and we have the most issues. We are looking to do a re-procurement in the Isle of Wight. We've done a bigger procurement across the other parts of Hampshire where we've had those challenges. Unfortunately, in that round, we didn't get any bidders for the Isle of Wight. So we've recognised that we need to do something different in the Isle of Wight to attract that. And we're starting those discussions with Michaela and with the NHS team now to make sure that we go out for a procurement that has a much greater chance of success on the island. Does that, I'll let you ask me more questions because I'm sure you've got lots.
So it would be helpful for the committee if we could have a plan and a timetable for improving dental services would be really good, and everybody's nodding their head with that. So
yeah.
If you could take that on board, please, Joe. And I think we've got Michaela going to speak now.
I was just sorry, just before you let Michaela come in, one of the things I wanted to say is we do have a plan. We are developing that plan. What on that plan is the recruitment for the island. There are two challenges that I think the committee really needs to be aware of that will impact on how quickly we can see success in that plan. So, and those two challenges, one is the national contract. So the national contract for dentistry that came into being in 2006 had put some restrictions around how much additional work could be put through. That contract is being reformed, and we've got the first of those reforms that have started now, which has increased the minimum unit of dental activity, so the minimum price rate. More of those reforms are coming in place in January, but that national contract has provided some disincentives within it, which nationally being reviewed, but part of our local plan will have to be in line with that national contract reform programme. And as I say, we're only in the first part of that and will be over the next year or so. The other issue is the workforce and the challenges around workforce that we've got. And again, in the report, as we've said, there are some national challenges, but some really acute challenges in the island. So the report will, the re-procurement will try to address those challenges, but there are some, there are some regional and national challenges around workforce that we need to address. One of those is how we can lobby upwards to ensure that we can create, make the best use of the University of Portsmouth Dental Academy, and to try and look at, can that be made a dental school, which will again attract more dentists into the area. So there are some short-term things that we can do, and we are doing, and can talk about that and provide you with a clearer plan of that if that would be helpful. But there are also some national challenges as well we need to address.
That's encouraging to know. Part of our frustration has been that the contract indeed, and how local feedback is that there are private dentists on the island that would have liked to expand and offer NHS service, but they were just ignored. But anyway, Michaela.
It's really helpful, thank you. Two bits of positive good news. So the first one is, I know that one of the major areas of concern to the committee, and all of us very understandably, was around accessibility for NHS children's dentistry on the island. And in the last 3 weeks, one of the large dentists on the island came forward and said that they were willing to accept everyone possible under the age of 18 on their lists, and that surgery has opened up their lists, and they actually directly contacted the schools to let them know that those lists were opening. So that's been incredibly positive, with more island children being registered for NHS dentist services. The other thing I wanted to stress, and I appreciate, again, none of this feels like it's could go quick enough, is that what Joe said about building local relationships is proving to be absolutely key. So I'm indebted to Joanna, who linked me up directly with some of the dentists who you had mentioned, Chair, were wanting to do more work on the island. And because we have got a team of people on the island, a number of those individual practices have contacted us, looking to have conversations. And Joe and I are meeting with colleagues, is it Wednesday, I think, or Thursday this week, Joe, around those discussions. So we are definitely seeing fruit of the ability to have local conversations. And some of that is just as simple as being on the island, isn't it? But there has been some positive progress, recognising we're still not at the stage of going out with the next procurement.
Thank you.
So a question I get regularly from constituents, as I'm sure you all do actually, is if this all goes well, when will they get an NHS dentist?
So I don't know the answer to that.
No.
Those timetable comes in, but so I don't know. I'm not going to sit here and say I know the answer because I don't. Joe?
No, and I suppose what we do know is that quite often when we go out for a procurement, any procurement, it can take up to 6 months, sometimes longer, depending on the size of the procurement. So I think, so the ones that have gone out, that went out in over the summer, of which the Isle of Wight was part of the bid, those were all to start from April 2023. So we were successful in 4 areas, so 2 in Portsmouth and others across, 1 in Southampton and 1 in Hampshire. So that, as you can see, that was a sort of a 9-month time frame that we had. I think we might need to do something even more flexible than that within the island. So it might be that if we're going out for additional UDAs as part of that recruitment, as that procurement, sorry, then again we would be looking at 6 to 9 months. But if we can do something more innovative or work with local dentists differently, then that might give us a chance to do something quicker. Having said that, we have to work within the bounds of the national contract, which is different to many of the other NHS contracts that we work with. So we're just trying to understand what flexibility is within that contract that will enable us to do something quicker. But that would be my hope.
Thank you. So effectively, are we saying there's enough capacity in terms of dentistry on the island? Dentists aren't prepared to accept the contract terms, which I know is out of your control, but the capacity is there.
With the new procurement, had we got a bidder for the island GDAs in this round, then yes, we would have felt that we had sufficient capacity, commissioned capacity for the island. The issue is more about the workforce.
Thank you. So to close on this, Joe.
Thank you, Chair. You're probably very bored of me saying this because I say it at most meetings, but I would really urge you to act really quickly on this, because month by month, week by week, day by day, the situation is getting worse for island people. And we're hearing that in the feedback that we're getting. And it's still one of the top issues that people contact us about, as it is with, council members, I'm sure. People are in a desperate situation and it's impacting every other service. So people are being, it's affecting their mental health. They're going to primary care because they're in acute pain. They're ending up at A&E. So I'm aware that it's affecting the hospital as well. It affects every aspect of a person's life. And the situation, I'm really glad that you recognise there are significant issues on the island in particular, because there are. And because of that need to travel off island, quite a few people do travel off island and have found mainland dentists, but that is not an option for the majority of people, either financially or as a time resource. So this is an urgent situation that needs addressing, and people can't wait 6 to 12 months. when they've already waited years. This is not a situation caused by the pandemic. We've had an issue here for as long as I can remember. And many people have never accessed an NHS dentist on the islands, and their children have never accessed an NHS dentist. So we are going to be have a huge backlog of need. And we're talking about preventative stuff. People on the island are struggling to get urgent and emergency dental care as well. So there's a whole host of issues that need addressing, and they really need addressing today. So it would be really helpful, to see the action plan and to see, because there is a will on the island. We've spoken to dental providers that are happy to provide support and to provide NHS services, but they just haven't been able to in the past. So there's a will here, and I understand today from the patient council chair that a new dentist, an NHS dentist, is visiting schools to talk about school children choosing options that would be helpful for should they want to become a dentist. So, you know, stuff is happening, but the dental providers need support. Thank you.
No. Oh, did you have for me to come back on that?
Yes,
Chair?
please.
Sorry, I jumped in. Yeah, no, I completely agree with you. I think we have some really significant challenges. The pandemic worsened the situation, but as you say, for some parts of Hampshire and the Isle of Wight, some of these problems were there before. So it's been exacerbated by the pandemic. I believe there is quite a bit we can do, but some of these challenges are linked to national policy, and the workforce and the training of dentists, and also the ability to attract international dentists into the UK and into the NHS. So there are numerous challenges that we must address at all levels. Locally, we're absolutely looking at how we can support in the short term and doing some work with NHS England around how we could look at some mobile dental options in some of our most poorly hit, or the areas where we've got the worst access. The Isle of Wight is there, as I've said. Portsmouth is another area, because of the levels of deprivation and the lack of commissioned activity in the city and in Gosport and Havant in particular. So we'll be doing that in the short term. Those plans are underway. We are doing some engagement work with Health Watch. We're looking at other flexible commissioning options. We're hoping to recruit to a post that will sit within the ICB that will work with us and for example, Michaela's team and the NHSE commissioning team to give us more capacity to take those ideas that the local providers are having and seeing how we can make that happen, again within the bounds of the contract. So we're recruiting to that post this week. I'm hoping we'll be successful, although it has been a challenge to recruit to, and this is our third time going out. So hopefully we will be successful. The other area that we're doing that I haven't mentioned is around oral health strategies. So working with public health and the local authority to look at how we can support those strategies more moving forward. So again, going into schools and working with children and going into preschools and also looking at care homes. So there's some of the schemes that we're working on at the moment. We're also, again, working with Portsmouth University to become a centre of dental development, which is a new sort of national initiative, which we hope the university is well placed to take up. And again, that would have a wider benefit across Hampshire and the Isle of Wight. And we've got some meetings about that again in the next couple of weeks.
Good, thank you. So plan and timetable, really important as soon as possible.
Yeah.
Certainly before the next meeting. Joe wanted to come back, and then we got Councillor Downer.
Thank you, Joe. And it is reassuring to know what plans you've got in place, and that you're considering the wider aspects of oral health and not just access to a dentist. I just wanted to mention that Local Health Watch are working with the Department of Health So we've raised our concerns collectively and individually, and ourselves and Healthwatch Portsmouth have a meeting in January with NHS England national dental leads to look at the way services are commissioned in the future, and to make sure that they understand the issues that people are facing, particularly in our local areas.
Yeah, thank you. I think that would be really helpful. And we've also had a lot of MP interest across Hampshire and the Isle of Wight, and some of our MPs have been very vocal in this area. And again, influencing upwards around pushing for the changes in the national contract, but also how we work with Health Education England around the training and opening up more training places. Is that something we could do? Again, could we lobby for the Portsmouth Dental Academy to become a dental school? Or no, I always get those two the wrong way around, so I probably need to just check that in the report, but so that they can take on undergraduates as well, and do that in their own right. So again, we can attract more trainees into the area, because we know that if you train in an area, you're more likely to stay in that area for the first couple of years, and that would really support us down in Hampshire and the Isle of Wight. And also, as I said, this Centre of Dental Development within the university. So we're doing all of those things. And again, looking at how can we support in terms of secondary care dentists and community dental services that Solent provide across the patch in some areas. So looking at all of those as well.
Good. Councillor Downer.
Thank you, Chairman. May I ask if representations have been made about the national level to bring it into more localised, so you can break free to make things easier? Would that be a point to make?
So I think the reason for delegating it down to ICBs was to definitely do some of that, so we could commission more flexibly, based on need and based on local population need, and think through that, and should create those relationships and provide more support to local providers. I think that's definitely part of the process. Some of the things like the national contract and the way how we decide training numbers, that is all done nationally. So again, I think it's doing what we can locally and influencing upwards and influencing national policy where we feel that needs to change. And again, as local authorities, local councillors and MPs, you've been really helpful in that and supporting us in that. So if you can continue that would be really helpful.
Thank you.
Thank you. And I'd like to thank Joanna for her remarks as well, but to hope that we're not in this position next year, because then you're going to get into the scenario of how long's a bit of string.
It's very reassuring, and I know Michaela Keats is very well briefed. It's very reassuring to hear the work and the aspirations that you have for dentistry on the Isle of Wight. So to reiterate, a plan and timetable would be useful. Yeah. But this committee is not going to. Sorry, Carl.
Apologies, my director's got to leave but I just wanted to say very quickly that I think what might be helpful if we could have for the oral hygiene health promotions a paper saying what actions are actually being taken by public health in the prevention aim, so that you bring a paper forward saying this has happened in the schools, this has happened in the lower. Just a short, I just wanted to recommend it, just a very short, not a paper, but one-sided of actions. And the other thing to say is that I've actually heard some good news about dentistry today in East Cowes. The local dentist there is taking on children. Which is really quite positive. Sadly, it's not for adults, but that's a step in the right direction. And I think that's something that needs to be really held on to. Finally, in fact, it was actually said, finally, we've got some movement. So sorry.
I will put that in the work plan and keep up to date. Simon.
Well, I do an update regularly to the committee, so I just include it in my public health update. That's
thank you very much. So just to round up on this one, this committee feels so strongly about the state that dentistry is falling into under National Health England and the particular commissioners that were brought in to resolve the problems that we have. They actually made it worse. And we want to make a proposal. And the proposal is that this committee requests that the island's MP ask the newly appointed Secretary of State for Health to make changes to the leadership of those responsible at a national level in the NHS for the planning, provision and delivery of NHS dental services due to the complete collapse of the existing structure for both patients and dentists under their tenure. So that's a proposal. Got a seconder. Councillor Quigley, and we'll go to the vote. Those in favour of that proposal? That's unanimous. Thank you very much. Right, on that bombshell to another thorny subject, patient transport.
Sorry, Chair, forget every time. So this will be a much shorter update, I think. And I'm sure those of you know me now, I'm nothing if not always honest. And I think I'd already explained this to Paul, but we have not made as much progress on this issue as we had planned. And the reason for that is, in all honesty, that as I explained in the first agenda item, that was our joint collective item on pressures in health and social care, we've been so busy managing the demand pressures over the summer and the range of critical incidents in particular we found ourselves in, that we did have a workshop set up in August with Wendy Pereira and Christopher Garnett and colleagues who are doing the work on this, and the Trust and myself, and we had to cancel it because of the operational pressures. So we are meeting again, in fact, next week. What we have done is confirmed the scope of the patient transport review, which was the first thing we were asked to do. And that has two main elements. So the first scope, which is what we discussed here at the original meeting, which I think was my first meeting back in June, was around how do existing patient transport services work to the island accessing health services.
Could that be shared with us?
It absolutely can, and I'm really sorry. We have got one A4 slide that describes the scope, and I apologise because I thought it had been submitted by someone for the papers and it hasn't been, so I apologise. But you can circulate that tomorrow. The second element of the scope, which I think is probably even more important, and certainly with reference to the information piece you've got in here on the elective surgery hub, is to widen the scope of the group to effectively consider what additional changes we need to make to our plans around patient transport in light of a number of service developments may happen. We basically want to say we need a transport policy and approach that is flexible enough to deal with any service changes that might come along the line. So the elective hub is already mentioned in the papers today. Leslie will talk about the community mental health and learning disability integration. And whilst we don't expect those to move services off the island, what we need to do is have a plan for transport that says if services do move, how do people access those? And we've already made reference to dentistry, where actually there is capacity to be registered in Portsmouth, but that doesn't work if you can't access, if you can't afford to travel. So that is the scope of the work, but we have not done all the work we plan to do, and I apologise, I'm being entirely honest. But Kathy Budden from the Trust is now working to us, and if it's okay with you, Chair, I think what I'd like to do is bring back a more detailed update to the next meeting. Apologies on that.
Michaela, we really appreciate your frank and direct manner. It's refreshing to this committee. Can we take that as an assurance that it will be given priority through the ICP, or do we need to make a resolution to that effect?
Can take my assurance if you're content to trust that, and again, it's not just me, it's a cross-organisational piece of work. So Wendy's involved, I'm involved, the Trust are involved, so it's collectively all of us working together. Colleagues might want to comment.
Don't fight over it. Who's next?
So I'm sure my director will jump in. Thank you. I understand the pressures which you're facing, absolutely. Then there are different levels of operation of patient transport. So I just wanted to just say something about our little bit, just for a second, if I may, which is a tiny little bit of which is obviously the patient transport scheme, which we operate from the council's perspective. So, we talked earlier about the significant financial pressures, and they are very, very significant financial pressures, which we sit next year. We've been very lucky that both we've been able to support that both in previous administrations and this administration's. Looking forward, the pressure is significant to the point that is a consideration for cuts. And I think it's only fair to say that now, so that people are aware of what the pressures are that this council face. And whilst it may only be in the region of 60,000, it's against a budget deficit of millions. And so we are facing real issues about that. I have my concerns about, obviously, when people go off island for treatment, but I recognise that that's a necessary part of the world that we live in. But it's how we manage it. So I'm really grateful to Michaela and the team for looking at that. But I just needed to deliver a very clear message now about the contribution which the council make to, it's a voluntary contribution, and that is very significantly at risk. And we know that as soon as you start talking about cuts to people that are going off the island in terms of their own ability to get off there, that creates a significant wave of feeling and emotions from people that use it. I just need to be really clear about it. It's one of the things that we will be discussing in the review of the £3 million cuts, which we have to make this year as a part of austerity. And we've done fantastically well in the previous administration and in this administration to hold on to it thus far, but it is a risk.
Thank you, Carl. Don't forget your button. Don't forget your button. Any questions?
Can I just come in there, Chairman, just to give a reflection on what's happening nationally? Under the Health and Care Act, there was a change in the current legislation where currently House Scrutiny committees have the power of referral to the Secretary of State where they believe there's a substantial variation in service delivery. And what happens then is that proposal was put on hold, and the Secretary of State appoints the independent reconfiguration panel to look independently at any major change in service delivery. The Secretary of State is going to take those powers over. That is being worked through at a national level. And I was at a National Scrutiny Officers Network meeting last Friday when we were discussing with Department of Health officials what substantial variation looked like. And one of the key elements to service change that will be looked at by the Secretary of State in future is something that has a unique impact upon a local authority area or part of its population. And to me, patient transport would have a unique impact on any service delivery proposals affecting island patients where they have to travel to the mainland. So in essence, I'm sort of giving early warning that patient transport will be a key element, because it will be something that the local authority, even if it has not got the power of referral to the Secretary of State, can actually ask the Secretary of State to ensure that they look clearly and concisely at any major service changes in the future. I'll just put that out there.
Paul, that's really useful. Thank you very much. So I'm looking at people around the room, and I think that's a really useful bit of information. Vanessa, Councillor Church.
Just like for Paul's benefit, it isn't our fault that we have one hospital in the middle of Newport. It isn't our fault or anything to do with the council or patients that everything is over there. And I think that's a point that we really should bring up. It's all very well everything being centralised, because supposedly it creates a better hub if you've got all the cancer people in Southampton, but it then totally ignores the enormous amount of travelling that everybody else has to do to get to that point. you know, stop car use, do me a favour, are we going to cycle to Southampton, for example? But I do think it's something that should be brought up. Thank you, Chair.
Michaela.
So the reason that we need to do the piece of work that we're describing is precisely that. So I just want to assure you that no one says we need to, you know, for example, to have cancer surgery happen in Portsmouth or Southampton because it's the best thing, and doesn't think about the transport impact. And that's precisely why when we had the conversation back in June, we said we absolutely need this working group that says when we make service change decisions, we recognise that there is an impact on people on the island, and you know, people like me and my families and all of us would recognise that, and that's why we need that working group. So I just wanted to assure you, no one in any way ever thinks we're going to move it there and we don't think about the transport implications, because I get it, we all get it. I just wanted to assure you on that.
Thank you, Michaela, for that intervention. So we'll move on now to item number 11, service changes, reconfiguration and development. So elective surgery hub update and mental health. So Leslie, are you going to do both of these? Elective surgery, Michaela, is that you?
It's fine. I'm really happy to give the two. Would you like the 2-minute version from me? Would that be okay?
Yeah,
Before I cough myself, I'm going to leave in a minute and take my germs with me, but I promise I'm not that. I'm well past being infectious, and it's not COVID. So, in terms of the elective hub, we talked about this. I'm trying to remember the meeting. I think it must have been June. And Jeannie Maskery joined us. Jeannie Maskery wrote the paper, which is in your pack, and you'll notice in there it's just an update against the timetable. What I did want to flag, and I hope offers some reassurance to the committee members, is that what the trust has agreed with the elective hub is not a guaranteed commitment of placing elective lists in that hub in Winchester, but is ad hoc use as and when we need it, which I think was where the conversation landed last time, and I hope offers some reassurance to councillors. And we've been in discussion with Health Watch around that as well. So, but it is a really good link to the transport discussion we were just having, which is if there is a need to relocate any elective surgery off island, then clearly the transport needs of all patients would have to be absolutely critical in that. But I'm hoping the paper is self-explanatory.
Leslie, your turn.
Chairman, before you go to that, is there any further actions that you want to take it in respect of the elective surgery? Do you want to, thinking about the patient transport, reinforce your concerns that whatever happens through this business case, that proper due consideration is given to patient transport for island residents?
I think that's a given and should be.
Right.
Yeah, I think that is already a statement, and if it's not a statement in that paper, I would agree that is our intention. Does that
Thank
help?
you, Michaela. Thank you for that reassurance.
Thank you, Chair. So the paper that's included in your papers today is largely the same paper that came to the Overview and Scrutiny Committee on the 12th of September. There's an update in the final section, but as you'll be aware, that was in the period of national mourning and was not a formal meeting. So I wanted to bring this back formally and update you on progress with this piece of work. So in terms of context, there was an independent, not informal, independent review of community mental health and learning disability services across Hampshire and the Isle of Wight completed earlier this year. That came to a number of recommendations that included the need for a shared clinical strategy across mental health, learning disability and community services, and it also recommended that we form one community mental health and learning disability organisation. The case for change that underpinned that recommendation is, I think, quite clear. I think there's there's an enormous change that's happened in terms of the NHS context, the formation of the ICB, the need to collaborate. The focus on place, I think, is really key and is one of the priorities for us in this work. The demands on community mental health and learning disability services have steadily increased. For many parts of our service, that was true pre-COVID, but it's much more evident post-COVID, and we continue to see particularly, well, actually you can see in the pressures talked about in the St Mary's Hospital, that translates into our community physical health services, in mental health services. We expect to see the aftermath of COVID for a good 5 or more years in terms of the impact on the country's mental health. And I think we see that most significantly in young people. At the same time, we're seeing increasing challenges around resource, great challenge around recruitment and retention of staff. And we have, I think I've said this here before, particular challenges around professional isolation on the island, and the real value that we've had over the last few years in connecting with our professional colleagues in the mainland to make sure that we've got the right skills, supervision, training, and so on. We collectively across trusts that deliver these services across Hampshire and the Isle of Wight believe that we can respond to that case for change more rapidly and more effectively by working together. And so we're very positive about the opportunity to form a new organisation. From an Isle of Wight perspective, it builds upon the work that we've been doing over the last 2 to 3 years with Solent Trust, where they've supported us through their partnership work to develop our No Wrong Door strategy and the implementation of that over recent years. It has made a real difference to us, and continuing that connection with mainland providers is really important. But what I think is even more important to emphasise is that it will not take services off island. That's not the intention at all. Our No Wrong Door policy, our strategy, is absolutely focused on integrated place-based working in the island. We absolutely value the delivery of our services alongside our primary care partners, local authority, voluntary sector, and so on. And that won't change. If anything, what I see from this opportunity is that it will strengthen our arm in that. It will allow us to be more resilient. It will give our staff the right support and skills. It will also, I think, give us a louder and more consistent voice around the ICB table, arguing for community and mental health resources. We're very actively involved in all of the work streams that are ongoing at the moment in order to deliver this work. The project to deliver the new organisation is being called Project Fusion. I keep saying to people that's not what we're going to call the new organisation, because I don't think it would be a great name for that, but the project to deliver it is called Project Fusion. And we're involved in all of the clinical transformation work streams, and what's been really pleasing to see is that they align really well with the existing transformation work that's happening on the island. So they include things like our neurodiversity services for people with autism and ADHD, our child and adolescent mental health services, our older people's mental health services, frailty, and so on. All those things that we know are a real priority on the island that we're focusing on already are also being focused on across Hampshire and the Isle of Wight, and that will, I think, help us in progressing those things further faster. So I think that was about one. Yes, absolutely. Yeah. And I guess that the final thing I wanted to say is that when we first went into partnership with Solent, we were very much going out, it felt like we were going out with a begging bowl, asking for their help. It didn't feel like that towards the end of the partnership, and it doesn't feel like that in terms of this new partnership and being part of something bigger. We have things on the island in our community and mental health services that are more advanced than they have on the mainland, and they're really interested in what we're doing. So, for example, our technology-enabled care is much further advanced. Our dementia outreach team, which supports people with dementia to stay in their own homes, our recovery service in mental health, all are really progressive new models of care, and we're having our mainland partners coming over and having a look and understanding more about what we do. And I think the other really key thing that we're really proud of is our lived experience engagements, our employment of peer workers, people who've got lived experience in our workforce, and our co-production of work that we're doing. That was all. Thank you.
Thank you very much, Leslie. Just a little point. When reports are submitted, can we have ownership of the reports? Because these last 3 reports, I think. Yeah. So, you know, just so that we know they're local people that we recognise.
Yes.
So I'll tell you what that is. I reflected the same. We're so obsessed with writing them together that what happens is one of us write them and 4 of us sign them off. But so the person who's written it never puts their name on the bottom, but we'll sort that out.
Councillor Quigley.
Question for Michaela. Is the elective surgery hub, is it still on target against the, I can't find it now, the build plan?
It is, unlike any NHS capital building project I've ever known. Whether it will stay, but yes, it is. It is currently on time now.
Smashing. So that means end of construction, 14th of March 2025.
Let's go to the end.
Any other questions?
Thank you. I just wanted to raise again our concerns we had about the lack of engagement with people in relation to the proposal of an integrated trust. And I note that in the report it says that there's some planned engagement, but I just wonder how people's voices what they'll be able to make a difference with.
The approach that we're taking to this is that in order to deliver all of the changes we need to deliver, this needs to be a new organisation that has the right culture. And so a number of principles have been developed through engagement with various people, including people who use services. And one of the core principles for establishing the new organisation will be co-production and community engagement. So that work is happening through the engagement work. Co-production is a key part of all of the clinical work streams. But I think one of the things that we have a real opportunity to do here, and it's not often you get an opportunity to design a new organisation. I don't think many of us will have that opportunity again in our professional lives. I think there's a fantastic opportunity here to design an organisation that has the experience of people who use the service at the heart of what they do, to make sure that's reflected in the way the board is developed, the way the service is, the organisation is constructed. So we're thinking about it from lots of different perspectives. It's absolutely a fundamental principle for the new organisation. And the other that, you know, from this perspective people will be interested in is about system working, delivering at place and making sure that we're really engaging with all of our partners in each place is another fundamental principle for the development of the new organisation.
Carl?
Yeah, what was going through my mind is I'm very familiar with co-production. Co-production begins right at the beginning, not halfway through a change. It's like now is the co-production, not we're going to have a new service, because co-production would ask what does the new service look like, not we've got to deliver. It's really technical, but I'm just trying to say co-production isn't something that we've been doing a lot of on the island, and we really should do a lot more because it's clear that it's happening nationally. But I just wanted to just say co-production is right at the beginning. From the second you say go, that's co-production. And if people are not involved in that co-production, then it's not co-production. So just
Can I just say, within our mental health and learning disability services, it is something we're doing a lot of. We do it as absolutely part of everything we do. We have someone with lived experience in all of our governance meetings. We have a really vibrant service user and carer forum that's involved in all aspects of service delivery. We have peer workers. We have people with lived experience involved in training and recruitment of staff. It's a very comprehensive programme, and one of the things that's stark is we're further ahead. So I completely agree with you. And no, I share your views. Yeah. So I completely agree. The initial piece of review work that led to these recommendations was not co-produced, and since then, as the providers are taking it over, we're absolutely saying that's essential right the way through. But I agree with you, at the beginning it wasn't.
Thank you. Councillor Church.
Yes, at the start of the 20,000, the Times ran quite a big article saying the two problems they saw for the coming 21st century was diabetes and mental health. And they were absolutely spot on. So I don't know who wrote the article at the time. Now, we keep talking about what we're going to do. What are we doing to prevent it, please?
So as Simon Bryant mentioned, and sorry, it may have been before you arrived, but the Director for Public Health was saying that his team and my team in mental health work very closely together. We have a mental health alliance on the island that is absolutely focused on prevention and early intervention. From a mental health provider perspective, our focus is on delivering treatment for people with serious mental illness, but we absolutely recognise that the earlier we get to people and the more that we can do to support our public health colleagues with prevention, then the better it is for everybody. So we're absolutely focused on that, particularly focused on suicide prevention and prevention of mental illness in young people. We've got new mental health support teams on the island that now go into all of our island schools. They're provided by the Isle of Wight Trust, by Mental Health Services, but in partnership with Barnardo's and Youth Trust. And they provide mental health education and interventions for young people in schools. And there's really good evidence that the sooner we get in with young people, the better the outcomes in the long term.
Well, Leslie would never think that it was me if I didn't mention gut biome, would I? Our celebrated officer has some other information to share with everybody.
Yes, Chairman. Because we're in contact as scrutiny officers across the area, Hampshire County Council, their House Select Committee, had a look at the same issue earlier, or last week it was, and they decided that they couldn't actually take the matter forward because they felt that they didn't have sufficient information on this matter and whether it constituted a substantial variation. I think, Chairman, because we've got such good, excellent working relationships with our health partners, I think we've got a very good reassurance about the local services will continue to be delivered locally. But I think part of Hampshire's concerns was the lack of this detailed engagement and involvement plan, because that's the key element, is making sure that everyone's engaged, everyone's involved. And I think what Hampshire is doing is sort of saying, look, we'll just stand back for the while and wait until we have more information. And I just wanted to share that's Hampshire's views, and they're also talking to their colleagues in Portsmouth and Southampton. But I think, I don't know what you want for a recommendation from here, Leslie, as part of the piece, as whether or not you want our approval to the proposal, subject to the detailed engagement plan.
Sorry. Yes, and also an opportunity to keep you updated as this develops, because it's still very early stages in this. There is a great deal more to do in terms of engagement and design of the organisation, in terms of the operating structure of the organisation. So yes, that would be helpful. Thank you.
Thank you, Chairman.
Well, I think we're confident that we know Leslie very well, and she's been very forthcoming was in previously, and also the fact that Health Watch are closely involved, and again we have excellent relationships with Health Watch. So I think if the committee think that that's okay, I think we'll take that as a reassurance, Leslie, and quite confident that you'll update us for or against as work proceeds. Right, we've done very well tonight, unexpectedly so, which brings us on to the last item, which is the work plan. Now, we've got very few of the permanent committee here, and I think we've got an addition to the work plan. Are there any amendments that you would like to see, or I mean, if you want to amend something you haven't thought of it here, you can always amend it after the meeting.
And also that goes for all our health partners and adult social care as well. If they believe there's an issue not already on the work plan.
Yeah, the work plan is open to all. So if there's something you want us to look at, then by all means, you know, nominate it. We're here to support as well as criticise.
And Chairman, it's also not necessarily stuff for the formal meetings. We only have 4 of those, and they're quite time precious. But if there's any, you know, like we had a very good dentistry informal meeting. So if there's some items that, you know, the officers feel would be beneficial to tell members about in a bite-sized chunk hour, please let us know and we'll help facilitate that.
Right, no questions. Vanessa.
Hang on.
I'm not quite sure that it's the right place, but I'll ask the question anyway. You might want to review the impacts of funding on adult social care and health generally after the budget's been set. I'm just wondering whether that's something that you would want to do or not. I'm not sure that I'm putting myself in the thumb. I might agree with that.
Thank you, Carl. We can have it as a
Chairman,
general question.
What we can do is Mel and I will have a look at the scoping of that, and possibly I see we got a few slots in June, so that will keep you actively engaged.
Right, Vanessa.
Yes, as John knows and councillors know, I sent an email that about free school meals for children. Now, I know this is adult social care, but what our children do now is what we will inherit later on. And is there any way that the committee somehow could support our MPs and the bill which Zara Sultana is putting before Parliament? Is there any way that this committee can put it through to Cabinet even, that we as a council basically should be supporting this bill about free school meals for primary school children?
Not seen that, Chairman. I would have thought that would have been more akin to Councillor Quigley's committee. If necessary, if Councillor Churchman gives me that information,
I'm happy to support it via our committee.
Yeah, we can share that with the relevant select committee or scrutiny committee and pass that forward.
And secondly, something was brought to my attention today. A few years ago, we had a campaign for people walking late at night or cyclists to wear distinctive clothing. And there was a classic example when I was driving back from Ryde this evening. Somebody ran across Fairley Road and just in a black tracksuit. Can we, as the council, recommend a campaign to remind people to wear something distinctive, keep death off the roads, is what I'm saying.
Chairman, that's more akin to council. We're fortunately all having all the
got
scrutiny chairs here tonight.
Oh,
That's Councillor Lever's
so
committee.
important.
And they've actually been involved in road safety campaigns, so we'll make sure that's right.
Good points, Vanessa, and we've got the right people here to address them.
Well, that's why I'm raising it.
Good question. So with that, any
we have members' questions.
Yes, members' questions. There we are, Richard.
I don't want to keep anyone any longer. Two very quick questions. I'll start with a simple one. On behalf of a resident that's had a back problem for 10 years and has been treated with pain relief, seen a physio. Physio has told them they need an x-ray, but they can't then get access to get a referral. What do they need to do? What's their next course of action? What would they need to do? A doctor can't get to see a doctor. They're not very confident and comfortable doing online, and they've been told they're on the list to see a doctor in person. Yeah, no, that's perfect. Yeah, that's perfect. So, yeah, perfect. I'll put you in contact. And the other one is, I'll start with the answer to the question, then I'll ask the question, and then I'll tell you what it is. So the answer to the question, listening to everybody tonight, I think is people, money, and the availability of both. The question asking is why, and you'll see what the why means, is all of these meetings, in fact, all of the scrutiny meetings we come along to, especially health, and we're desperate to hear good news. We're desperate to give them good news. Everyone's desperate to give good news. Great things are being done. People are working really hard. But if you stop the average person in the street and ask them what they think about the healthcare system, they'll tell you that it's worse than it was 10 or 12 years ago. Life expectancy is reduced. We can't see a dentist. Getting doctor's appointments are very difficult. So all the hard work doesn't seem to be even to get us back to where we were. And this is my big concern, is we're talking about getting back to this level of service that we already had. We've not got any further forward. So back to that is why, and I think from what I've heard tonight, the answer is people and money. And I suppose then the other question is to us as a scrutiny committee, what can we actually do to improve it? Because I just worry that we're going to keep going round and round and round, having these same conversations when we all actually know the elephant in the room is people and money. And you don't have to answer that all now, because I know you're in it. But it's.
We've got recruitment retention at the March meeting in the work plan. But yeah, big question, Richard.
Chairman, if you're happy for me to try and answer the question, I think the challenge comes as a result of a lack of investment in adult social care over the last 40 years, if not longer. Adult social care is means tested, whereas health isn't. And that in itself has challenges. We have seen a significant number of proposals for reform over the past 25 years. There's been white papers, there's been green papers, there's been draft bills, and now we've got legislation. When it comes to actually doing something, we consistently see a move away from adult social care reform. We've seen it only in the past month or so, with the adult social care reform agenda being pushed off for 2 years. What that means in practical terms is 2 years is a general election. Nobody thinks that reforming adult social care is a vote winner, any which way you look at it. So I think we're looking at an even longer delay than that. Until there is consistent investment in adult social care, as there has been in health, and I think talking about how much that is probably isn't very helpful in this forum, and I know that my colleagues in health would have a similar view in terms of the lack of financial investment in their services as well. But until we can solve the challenges we see in supporting older people to age with respect, with dignity, in the place that they choose to call home, we will continue to see the challenges that we have. So yes, your short answer of money and people is absolutely right, but it's about getting the money and the people in the right place to really make lasting change for local island residents. And that's my primary focus, but more widely the rest of England.
I add to that. I think what I would be asking, I don't know if it's within the, is that you actually write as a committee in your own right to the local government association, to the Minister for Health and to the Chancellor, because the reality is next year there will be cuts to the service, which is devastating, as has been said by Michaela there. The impacts are quite significant because we just do not have the funds to run adult social care next year. And I don't know if you can do that or not, but if you have any influence over getting some more money into this council right now for adult social care to address the issues, then it's now or never, because that's the position that we're in. Is that possible? I don't know if that's possible.
We can action that, Carl. Thank you. I think, Michelle, did you want to make comment on Richard's first question?
Sorry, I'm struggling with my camera. Sorry, what was the first question again?
He had a local resident was.
Oh, yes, yes. Actually, interestingly, we don't routinely X-ray lower backs anymore. Those referrals are rejected by radiographers. We actually usually go straight to MRI. So I thought it was quite interesting that the physiotherapist suggested that in the first place. But I'm sure, I think between yourselves, you had a resolution to that problem. So I think they probably need to see their one of their health professionals in primary care, and that actually would be an ideal case for the musculoskeletal first point practitioner, was going to be my answer. So thank you, Chair.
Thank you, Michelle. Richard, you happy with that? Leslie?
Just in response to the second question, I completely agree with Laura's point about this is resource in the wrong place. So I think in addition to the people and the money, it's about culture and about clinical pathways. And we run a national illness service, not a national health service. The demand on our services has completely changed. And whilst in any acute hospital, there are amazing things happening that would never have happened 10 years ago, and people are benefiting from those kind of technological advances, in reality, the vast majority of people that need healthcare now have got multiple long-term conditions, frailty, dementia, and so on, and we're not geared up for that. And at the moment, what we tend to have to offer people is hospital care. And the last thing you need, but in most cases, if you've got multiple long-term conditions and frailty, is to go in a hospital, because that will disable you further. And we simply haven't, it's not just adult social care that hasn't been invested in, it's physical health community care as well. And that's what we need, a real focus on community and supporting people to stay in their own beds.
Michaela?
I think we should finish with a quote, which I thought was exactly spot on, which describes what Leslie is just saying, which was, I don't know if anyone saw a couple of weekends ago, the chair of the Royal College of Emergency Medicine was talking about the challenges that the NHS and social care find themselves in. And he said, and this has stuck with me, and I think we should try and remember it as we move forward with our plans. He said, for the elderly, hospitals are like lobster pots. They are incredibly easy to get in and impossible to get out of, and that is exactly how it feels at all points. And I just and he, you know, I thought it was an absolutely spot on quote, and that lobster pot might be something we want to retain in our heads as we move forward.
Good. Well, thank you everyone for attending, and thank you everyone for your contributions. I hope you all found it worthwhile, and we look forward to the next round of meetings, especially the informals.